We'll begin now with the meningococcal vaccines with an introduction by Dr. Stevens.
Thank you. Again, I want to thank the ACIP and CDC for the last 4 years in terms of my service on this committee. So again, thank you very much. Today, we're going to be focusing on serogroup B MenB booster doses in persons at risk for serogroup B meningococcal disease. ACIP recommends a MenB primary series for persons at increased risk for serogroup B meningococcal disease. Booster doses are not currently recommended for persons at increased risk. At the February 2019 meeting, data was presented to ACIP on the persistence of immune response following MenB, the MenB primary vaccination series. Immunogenicity, safety, and persistence of the MenB booster dose was also presented. A great evaluation, evidence of recommendations framework for MenB booster doses was presented, and the work group's interpretation and policy options for MenB booster doses. So the group activities subsequent to that meeting have been a review of the feedback provided by ACIP, a discussion of potential programmatic challenges for MenB booster doses, specific updates proposed to the CDC guidance, CDC outbreak guidance related to booster doses, implementation during outbreaks, and there has been a development of an updated ACIP statement to harmonize existing meningococcal vaccine recommendations and potential MenB booster recommendations into a single document. Our agenda today is to summarize the immunogenicity and safety data and review grade, ETR, and policy options for MenB booster doses in persons at increased risk. Sarah Mabahi will present that, and I want to thank Sarah for all of her work and effort in corralling, if you will, the working group on a number of occasions. And also she'll present the updated ACIP statement for meningococcal vaccination in the United States. So we will have 2 votes on MenB booster doses in persons at increased risk, and a vote on the updated ACIP meningococcal vaccine statement. And this is a list of the working group members. Again, I want to thank both the members on the ACIP and the other members for their work in this area, and also the CDC contributors to this. And with that, I'll introduce Sarah.
Thank you, Dr. Stevens. And I also want to sincerely thank Dr. Stevens for his leadership of this work group over the last couple of years. We've really enjoyed having you as our chair. Good morning. Today I will be summarizing data evaluated by the work group to inform policy options for serogroup B meningococcal vaccine booster doses in persons at increased risk for serogroup B meningococcal disease. At today's meeting, I will summarize information previously presented to ACIP at the February meeting. This includes reviewing the rationale for serogroup B meningococcal or MenB booster doses in persons at increased risk for serogroup B meningococcal disease, summarize the work group's interpretation of the persistence of the immune response following a MenB primary series, and immunogenicity and persistence of a MenB booster dose. Summarize the grade and ETR for MenB booster doses in persons at increased risk, and finally, review the work group's considerations for policy proposals related to MenB booster doses. Meningococcal disease is a serious infection that can progress rapidly. 1 in 10 patients die despite antibiotic treatment, and among survivors, 1 in 5 have long-term sequelae. The incidence of meningococcal disease continues to decline in the United States, with an incidence of 0.11 cases per 100,000 population in 2017. Serogroup B now accounts for approximately 40% of all cases. While incidence is low in the United States, certain individuals are at increased risk for serogroup B meningococcal disease. These include persons with complement deficiency, complement inhibitor use, anatomic or functional asplenia, and microbiologists routinely exposed to Neisseria meningitidis isolates. The magnitude of increased risk in these individuals can be up to 10,000-fold. Based on the population estimates for each group, these individuals comprise less than 0.1% of the U.S. population aged at least 10 years. In addition, persons may be at increased risk due to a serogroup B meningococcal disease outbreak. During a college outbreak, the magnitude of increased risk is approximately 165-fold and is even higher in freshmen, on-campus residents, and Greek life students. Approximately 35,000 college students are at increased risk annually due to an outbreak. In February 2015, ACIP recommended that persons aged 10 years or older at increased risk for serogroup B meningococcal disease receive a MenB primary series. These groups are also recommended to receive quadrivalent meningococcal conjugate or MenACWI vaccination with booster doses every 5 years thereafter for as long as risk remains. In addition, in June 2015, ACIP recommended that adolescents aged 16 to 23 years may be vaccinated with a MenB primary series based on individual clinical decision-making with a preferred age of 16 to 18 years. College students are at increased risk for serogroup B meningococcal disease and outbreaks compared to similarly aged young adults who do not attend college. 13 serogroup B outbreaks have been reported since 2013 to date. In all of these outbreaks, a MenB primary series was implemented as part of outbreak response. 2 of these outbreaks occurred at a New Jersey university during a 3-year period. During the first outbreak in 2016, MenB FHBP vaccination was recommended for all undergraduates. In the most recent outbreak reported in February 2019, MenB vaccination was again recommended to all undergraduates, and for the first time, booster vaccination was also recommended for students who completed a primary series at least 1 year previously. Thus, college students are the primary group at increased risk for serogroup B outbreaks who may have received a MenB primary series as healthy adolescents. Current MenB vaccination coverage among adolescents is low, with approximately 15% of 17-year-olds receiving at least 1 dose in 2017, though coverage has steadily increased since licensure. Additionally, several serogroup B cases have been reported in patients who received MenB vaccination. Of the 5 reported cases to date with any MenB vaccine, 3 were fully vaccinated with MenB4C, 1 was partially vaccinated with MenB4C, and 1 was partially vaccinated with MenB FHBP. Among those fully vaccinated with MenB4C, 2 had known underlying conditions that may have increased their risk for meningococcal disease, and 1 was a young adult with no known conditions. The interval from last MenB dose to disease onset ranged from 5 to 26 months. Preliminary analysis on the strains showed that potential protection is dependent on just 1 of 4 antigens, NHBA, and human serum bactericidal activity, or HSBA, results suggest that MenB4C likely confers limited protection against these strains. No isolate was available for the patient who was partially vaccinated with MenB FHBP, and thus the strain could not be analyzed further. Information on these patients is not sufficient to evaluate or compare effectiveness of MenB products. In summary, although incidence of serogroup B meningococcal disease is low in the United States, a small group of individuals are at substantially elevated risk. ACIP recommended a MenB primary series for persons at increased risk over 4 years ago. Evidence presented to ACIP at the February meeting suggests that waning of immunity occurs within 1 to 2 years following primary vaccination, and thus some vaccinated people may no longer be protected. Serogroup B outbreaks among college students continue to occur. One university to date has implemented off-label and ACIP recommendations for a booster dose. Finally, no further data on persistence following a primary series or booster dose are expected from the manufacturers. Additional data on MenB effectiveness and duration of protection in adolescents and adults or in U.S. populations may take years to generate. Now I will review the work group's interpretation of the persistence of the immune response following a MenB primary series. This figure summarizes clinical trial data for both a 3-dose, shown in the purple and dark blue bars, and a 2-dose, shown in light blue bars, MenB FHBP primary series, with each panel representing data from baseline or pre-vaccination through 48 months post-primary series for each of the 4 test strains. The work group's interpretation is that antibodies wane by 12 months following completion of a MenB FHBP primary series, and then remain stable for up to 4 years in healthy adolescents. For MenB4C, 4 clinical trials, each shown in a different color, have been conducted to assess immunogenicity and persistence to each of the 4 vaccine antigens shown in the different panels through 7.5 years post-primary series. Persistence following a MenB4C primary series was difficult to generalize due to the elevated baseline titers in 2 studies, heterogeneous results by vaccine antigens, different time points assessed in different studies, and more limited persistence data for NHBA, which contributes most to strain coverage in the United States. In light of this, the work group's interpretation is that antibodies wane by 2 years following the primary series in healthy adolescents and adults, though they may wane earlier. In addition, persistence of MenB primary vaccination against diverse serogroup B strains, including from college outbreaks, has been assessed in several observational studies. Variable patterns of short-term persistence were observed when measured up to 12 months post-vaccination. In another recent study to assess seroprevalence at Princeton University following the 2013 outbreak, suboptimal short-term immunogenicity followed by substantial antibody waning to the outbreak strain was observed in students vaccinated with MenB4C. At 2 months post-vaccination, 61% of students had an HSBA titer of at least 1 to 4, which declined to 24% by 20 months post-vaccination. In summary, given the variable rate of waning between vaccine types and between studies, antibody persistence following a MenB primary series was difficult to generalize across the 2 vaccine products. It must also be noted that the 2 vaccines are completely different, and evaluations of immunogenicity and persistence were conducted using different strains and immunologic endpoints, and thus cannot be directly compared. However, the work group felt that by 1 to 2 years following a MenB primary series, booster vaccination is indicated for persons who remain at increased risk. Next, I will review immunogenicity and persistence of a MenB booster dose. Immunogenicity and persistence of a MenB FHBP booster dose administered 4 years after completion of either a 2 or 3 dose primary series demonstrates a robust immune response at 1 month, with gradual waning and evidence of persistence through 26 months post-booster dose. Thus, the work group's assessment is that the immune response to a MenB FHBP booster dose persists for at least 2 years in healthy adolescents, and given the gradual antibody decay pattern, may last longer. For MenB4C, regardless of timing since completion of the primary series, whether 2, 4, or 7.5 years, a robust immune response was demonstrated 1 month following either a MenB4C or investigational MenABCWY booster dose. No studies assessed persistence of a MenB4C booster dose. However, following a booster dose with the investigational MenABCWY vaccine, which has the same MenB component as MenB4C, antibody persistence was observed through 12 months post-booster for most antigens. While there are no data on immune persistence following a MenB4C booster dose to inform the workgroup interpretation, the workgroup took into account the demonstration of persistence of an investigational MenABCWY booster dose through 12 months, as well as modeled data presented by the manufacturer at the February meeting suggesting that persistence is likely several years. To summarize, a MenB booster dose elicits a strong immune response, and the persistence appears to exceed that of a MenB primary series. Thus, the workgroup's interpretation is that antibody persistence of a MenB booster dose is likely at least 2 to 3 years and may be longer in healthy adolescents and adults. Next, I will summarize the grade and ETR for MenB booster doses in persons at increased risk for serogroup B meningococcal disease. Our overarching policy question was, should persons vaccinated with a MenB primary series who remain at increased risk for serogroup B meningococcal disease receive a MenB booster dose? The population was persons aged 10 years or older at increased risk due to specific underlying conditions in microbiologists, and persons exposed during a serogroup B meningococcal disease outbreak. The intervention was either a MenB FHBP or MenB 4C booster dose, and the comparison was no booster dose. Outcomes of interest related to MenB booster doses were identified by the workgroup, though only data on short-term immunogenicity, persistence of the immune response, and serious adverse events were available. For grade, we had a total of 4 PICO questions, 2 for each group at increased risk, and 2 for each MenB vaccine. First, I'll start with persons at increased risk due to underlying conditions or microbiologists. For both MenB FHBP and MenB 4C, the evidence type across outcomes was a 4, indicating that the overall certainty of evidence in this population is very low. The workgroup also reviewed additional considerations as part of the evidence to recommendations framework. Persons at increased risk due to certain underlying medical conditions and microbiologists comprise a small group at substantially increased risk. Thus, in this group, prevention of serogroup B meningococcal disease is an important concern. However, immunogenicity to MenB 4C is reduced in persons with complement deficiency or complement inhibitor use compared to healthy controls, and these persons may be at increased risk for meningococcal disease even if they develop antibodies following MenB vaccination. Thus, in these persons, the desirable effects of vaccination may be more limited compared to others in the target group. The undesirable effects of booster vaccination are expected to be minimal. Safety of the MenB primary series has been demonstrated in several large evaluations in healthy persons, though no data on booster doses, including repeated doses, are available in persons with underlying conditions. In a survey, the majority of pediatricians and family physicians state they would recommend a MenB primary series for children at increased risk, demonstrating acceptance of MenB vaccination, though there is a disparity by provider type, which may reflect levels of awareness or feasibility. There are no data on cost effectiveness in this population. Thus, the workgroup's interpretation is that for this population at increased risk, serogroup B meningococcal disease is a problem of public health importance. The desirable effects of a MenB booster dose may vary in persons with underlying conditions. The undesirable effects are likely minimal. The intervention of a MenB booster dose is favored, but there is very low certainty of the evidence. The target population may feel uncertain that the desirable effects are large relative to undesirable effects, though there is important uncertainty in how much these persons value the main outcomes. A MenB booster dose is probably acceptable to key stakeholders, though it is uncertain whether the intervention is a reasonable and efficient allocation of resources or is feasible to implement. Thus, the majority of the workgroup were in favor of proposing MenB booster doses in this population. Next, I will review grade and ETR for persons at increased risk due to a serogroup B meningococcal disease outbreak. For MenB FHBP, the evidence type across outcomes was a 4, indicating that the overall certainty of evidence is very low. For MenB 4C, the evidence type was a 3 or 4 across outcomes depending on study design, indicating that the overall certainty of evidence is low. The workgroup also reviewed other considerations as part of the evidence to recommendations framework for this population. 7% of serogroup B cases in the United States are outbreak-related, and college students are disproportionately affected. Limited data are available on effectiveness and duration of protection in adolescents and adults, and no data are available in U.S. populations. Following mass vaccination with MenB 4C in a region of Quebec, Canada, experiencing increased rates of disease, the vaccine was estimated to be 79% effective in persons under the age of 20 years up to 4 years post-vaccination, though the confidence intervals were very wide. However, an additional factor is that the evidence to date suggests no impact of MenB vaccines on meningococcal carriage, thus herd immunity is unlikely. As the safety of a MenB primary series has been demonstrated through multiple evaluations following mass vaccination during outbreaks, the harms are likely to be minimal for a booster dose. The workgroup also reviewed factors specific to college outbreaks. All 13 universities that experienced outbreaks since MenB vaccines became available implemented MenB primary series, indicating acceptance of MenB vaccine to stakeholders, though first dose coverage varied widely, which may reflect values, feasibility, or other factors. Additionally, one university to date has implemented a booster dose even in the absence of ACIP recommendation, reflecting acceptance of this intervention. MenB mass vaccination during college outbreaks is resource intensive, though is estimated to be more cost effective than universal vaccination of all students at college entry. Outbreaks require intensive coordination, significant human resources, and action among multiple stakeholders to efficiently respond within a short time. MenB booster doses may create additional complexities, though colleges have already demonstrated feasibility of conducting mass vaccination under very challenging circumstances. Indeed, additional challenges related to booster dose implementation were noted at the New Jersey University, including additional communication and logistical challenges related in part to the lack of an ACIP recommendation, as well as challenges in determining booster dose eligibility. For example, if a primary series was completed and which product was used. Thus, the workgroup's interpretation is that for this population at risk during an outbreak, serogroup B meningococcal disease is a problem of public health importance. The desirable effects of a MenB booster dose may be large with minimal undesirable effects. The intervention of a MenB booster dose is favored, but there is very low certainty of the evidence. The target population may feel that the desirable effects are large relative to undesirable effects, and there is probably variability in how much these persons value the main outcomes. We considered that the intervention of a MenB booster dose is acceptable to key stakeholders, a reasonable and efficient allocation of resources, and feasible to implement. Therefore, the workgroup is in favor of a MenB booster dose for persons at increased risk during a serogroup B outbreak. Next, I will summarize the workgroup's deliberations for MenB booster dose policy options in persons at increased risk. To summarize, the workgroup reviewed data I just presented on the persistence of the immune response following a MenB primary series, immunogenicity, persistence, and safety of a MenB booster dose, and results from the grade and ETR evaluations. The majority of workgroup members agreed upon the need for and timing of MenB booster doses. A small minority felt there was insufficient evidence on the safety and efficacy of MenB booster doses to inform policy options. The following slides represent the views of the majority of workgroup members. In summary, the workgroup feels that MenB booster vaccination is necessary to sustain protection in persons who remain at increased risk. The workgroup suggests that a MenB booster dose is indicated at 1 year following completion of the primary series. Greater persistence is expected after the booster dose, and thus a longer interval for repeat booster doses may be considered. Given the serious nature of meningococcal disease, the workgroup feels that the potential benefits of MenB booster vaccination outweigh potential risks in this population. As with MenB primary vaccination, challenges in the implementation of MenB booster doses are anticipated, but the workgroup feels that the potential benefits of booster vaccination justify the additional implementation efforts that will be needed. Thus, the workgroup proposes that ACIP recommend MenB booster vaccination in persons aged 10 years or older at increased risk for serogroup B meningococcal disease who previously completed a MenB primary series. This recommendation does not apply to persons who previously completed a MenB primary series as an adolescent based on individual clinical decision-making and who are not at increased risk for serogroup B meningococcal disease. For persons with complement deficiency, complement inhibitor use, asplenia, or microbiologists, a MenB booster dose is recommended 1 year following completion of a MenB primary series, followed by booster doses every 2 to 3 years thereafter for as long as risk remains. For persons determined by public health officials to be at increased risk during an outbreak, a one-time MenB booster dose is recommended if it has been at least 1 year since completion of a MenB primary series. A booster dose interval of at least 6 months may be considered by public health officials depending on the specific outbreak, vaccination strategy, and projected duration of elevated risk. ACIP will be asked to vote on the policy proposal for MenB booster doses in persons at increased risk for serogroup B meningococcal disease. In advance of this afternoon's vote, we would like to ask for any additional feedback on the workgroup's policy proposal for MenB booster doses.
Open for comment, questions from the voting members. Dr. Atmar.
Could you remind us of the basis for the original approval in terms of the MenB vaccine? I mean, we're making recommendations here based on immunogenicity and safety, and the original recommendations were made also based on immunogenicity, as best I can tell from the meningococcal vaccine recommendations. Is that correct?
That's correct. Immunogenicity data for both vaccines was reviewed when making the recommendation for persons at increased risk as well as for adolescents who are not at increased risk. We don't have any vaccine effectiveness data or duration of protection estimates that informed that policy.
And then my other question relates to a cost effectiveness assessment that's I understand was done for the original recommendation, and what the extra cost and benefit would be for a booster recommendation.
We did not conduct a formal cost effectiveness evaluation because these recommendations are really for a very small group of individuals at increased risk. We are not considering booster recommendations for adolescents who are not at increased risk, which is a much broader population. We attempted to look at some of this, but we found that there was such wide variety in the assumptions that we would have to make. There was such a range in our estimated numbers needed to vaccinate based on uncertainty around the level of increased risk, et cetera, the population size, et cetera, that the numbers really weren't very meaningful, which is why I haven't even presented those.
Can you remind us of the total estimate size of the population that you're talking about? Not, I guess, both for increased risk and also the average number of college students that are vaccinated during an outbreak the last couple of years?
It is, let me go back.
Slide 7.
Slide 7, please. Yes, so it's a little under 300,000. And that the college students are about 35,000, so that's taken into that estimate. These I should point out, these are estimates too. If you take, for example, those with complement deficiency, the top line, the majority of people who have complement deficiency are not aware of their deficiency. Often people will find out after their first episode of meningococcal disease or another infection, or if they have family members with it.
Dr. Maldonado.
Yeah, thank you. That was a nice presentation. Since this is a booster recommendation, and I think, as you know, pediatricians are somewhat concerned about how to counsel families given the very, very low risk of disease. I think that in addition to giving incidence and I would hope that maybe there would be actual numbers of cases, because that helps the pediatrician. For example, looking at the 2017 surveillance data from CDC, there's a total in all ages of 134 cases of MenB disease in the U.S. And so I think it would help a pediatrician to counsel the family given the level of risk in that age group. That would be helpful. Thanks.
Thank you.
Dr. Stevens.
So just to respond to Dr. Atmar's question, the license of the B vaccines is based on immunogenicity. The correlate of protection is the serum bactericidal assay, and that's been a standard for a number of years for most meningococcal vaccines. I do think to comment on another question is the complement inhibitor issue. I think even though we are recommending vaccination and booster vaccination in this group, we still haven't particularly solved this problem in terms of the seriousness, and we presented data on that in the past. So, but this is, as was pointed out, a small group that we're recommending boosters for at this point in time.
Dr. Hunter.
Yeah, I was wondering if our college health and NACHO and ASTO liaisons could comment on the following issue, that if there's an outbreak on a college campus, how much the booster recommendation would help in the implementation of a response to that, in that you may or may not need to ask before you vaccinate what their history is, and if you don't have a reliable vaccination history, whether that would be helpful.
Can we ask ACHA behind you also?
Yeah, this is Susan Even, ACHA. I mean, I think you've pointed out something that we've thought about, but there's likely in an outbreak situation, the access to vaccine information on which, if they had MenB before, the students are unlikely to know which ones they've had, and it depends on the record keeping and the ease of record keeping. I mean, if you have all the students' immunization quickly available in an electronic record, that's one thing, but it's not. That's not a general practice. So I think we would be using. My assumption is that a campus would use the vaccine that was most readily available, administer that as widely as possible. In the situations where someone was aware of the vaccine that they'd had before, if they'd had 2 doses before, we would, make every attempt to use that same vaccine. The speed of the response seems to be more important at that point, and when you're in that situation.
Yeah, so from NATO's side, I think, yeah, it's a good point, Paul. I think it depends on the size of population that you're trying to reach. If you have 30 people that you potentially expose, it's really different than if you're talking 3,000 people. I think that either way, if you say that there's been a meninge event and you need to vaccinate a very large number of people, even if you're saying we just want to get people who've never been vaccinated before, either way, I think there's a real potential for giving, if there's no recommendation, you're still going to give extra doses because there are people who vaccinated, they didn't realize, and then they got vaccinated. So I think that on balance, I think this is definitely helpful. I think this clarifies the question. I think it's an obvious question that begs, hey, we know that after a couple of years, your immunity really wanes. And, to me, it's an obvious question, an obvious concern, and there's potential utility to it. I think there is an issue in terms of getting everybody's vaccination status right and over-vaccinating. I think that looks like you can go down to 6 months or more, or after, which makes, a better chance that people remembered what they got within the last 6 months at least. So I think there is an issue in the concern you described, but I think on balance, I think this is something that public health would welcome the recommendation of.
Dr. Mishon.
Yeah, I wanted to ask a question of the working group. So I really appreciate the systematic way you worked through the issue and the desire to fill a hole in our recommendations, which I think tries to provide helpful guidance to clinicians. These groups up here, different than the outbreak settings, are in groups that have a more lifetime risk. And I understand the limitations of the available data, but also the desire to provide recommendations beyond a single booster dose. And I just wanted to ask the working group if they could comment separately on reassuring us that they don't have concerns about safety. I mean, I know we don't really know about effectiveness of repeat vaccination after even, a first booster, but if you could just comment on the safety issue.
I think that from a safety standpoint, and we did look at those data, and that there isn't a major concern around safety of repeat of booster doses. I think there is, based on the data that was emphasized, that this is a memory-inducing vaccine, and therefore a booster dose should provide significantly longer protection than the original priming series. But we don't have data to support that. But I think that is that's the message from the limited data that's available. Sarah may want to also comment.
Dr. Alt.
Just in follow-up then, if this recommendation were to go forward, I think it would be important for those at a lifetime risk to generate those data, because it may well be that the interval can be longer as more doses have been delivered.
Dr. Eche.
So that's what I was thinking as I was looking through it, and I was thinking this includes the 100,000 of people that have sickle cell disease that are assumed to have functional asplenia. And so the recommendation is that they're going to receive this every 2 to 3 years for life. And seems like we really don't have the data that shows effectiveness, nor do we actually have the safety data beyond one booster dose. So I'll just keep wondering on what foundation we're going to make that recommendation that individuals who have sickle cell, who have functional asplenia, should be immunized with the primary series and receive immunization every 2 to 3 years for life.
Go ahead, Dr. Stevens.
So I think you raised an obvious dilemma, how we know this vaccine does work in terms of efficacy. It does prevent disease in high-risk groups, and in those individuals with functional asplenia, the risk is significant. So you weigh we use things like prophylactic penicillin in some of these individuals for other increased risk that is, for lengthy periods of time. So I think my response is that yes, I would believe that a booster could help protect these individuals. How often you give that booster is the question that's on the table. How long do we continue to make these recommendations in this particular group? I agree with Dr. Atmar that we need more data on repeated boosters to your question.
And just to chime in on the sickle cell question a little bit more, the reason that they're considered, a big reason why they're considered a risk group for meningococcal disease in general is that if they do get it, they have extremely high case fatality rates. 60-70% of people can get an overwhelming post splenectomy infection. And so I do think it is important to consider them in this population.
Just a follow-up. I do understand why this needs to be done. I'm just wondering how we are going to represent in the recommendation that this is a recommendation we are making with limited available data. That's really, it's obvious that they need it just to make sure that we are hoping, and that's something I think ACIP could and the manufacturer could commit to, which is to make sure that we do collect this data. What happens usually is that after those things start, this data. So if it was a way to make the recommendation that we will overlook, or if ACIP will review this recommendation in 5 years, a way to kind of put in place some data collection of safety.
Dr. Whitney Williams, did you? No. Okay, sorry, forgive me. I thought, it was it.
I was just wondering if it would be interesting to look at this vaccination strategy as an added value above and beyond chemoprophylaxis. Following the comment, I think people on eculizumab there were thoughts about giving them prophylaxis because the meningococcal disease was non-vaccine type. So how much more do you add by boosting with MenB? And the other question that I had was for microbiologists. I am one. Whether or not I want a vaccine every 2 to 3 years, I'm not sure. But so that study is a study from 2005. Do you think that the process in the lab is now safer working with biosafety level 2 and above? And is that risk still the same? I just find that this recommendation is very heavy in terms of the boosting.
Yeah, I think these are issues that we've really tried to understand on the work group a little bit better. I think we recognize that every 2 to 3 years is a pretty short interval, but the work group, and even when this was brought to ACIP several years ago, initially felt that we didn't have the data to say that we could wait 5 years. The data is just not there. People will be left unprotected. I do agree we have some gaps in our data. We don't have more refined estimates among microbiologists since that paper. Like Dr. Stevens mentions, there's still a lot of issues to be worked out with people taking complement inhibitors and how much vaccination actually protects them. But I think the work group felt that we know that they're at exceptionally high risk, and there is a possibility of benefit in these groups, so we should continue recommending not only a primary series, but also booster vaccination in this group.
Dr. Messonnier.
Yeah, I just wanted to point out two things. One is, we do have a routine cycle now of review of these recommendations every 5 years, and so that will happen routinely. ACIP is certainly welcome to include in their statement language directing CDC to, try to find ways to evaluate this. I would say that it would be difficult to have a standalone study, and so what we would be looking to see is if in any of these groups there are existing studies where folks are, for example, drawing blood from patients with sickle cell, because it would be more efficient for us to try to add on. So we'll look for collaborators who actually have clinical care of these patient populations to see if there's a way to, answer some of your questions. And I'm saying it here because perhaps somebody in our larger community might, for example, know of a researcher who's working on sickle cell disease and be able to connect us with somebody that would help us to answer these questions.
Dr. Bernstein.
I struggle a little bit with, since these the two vaccines are not interchangeable, I struggle a little bit calling it a booster if we really, in that population of college students during an outbreak, that we do not know what product they received. Are we really doing a service in giving them a single dose of vaccine, or since one of the two products is a 0-1 month schedule, should we be extending our recommendation for those that have not received MenB vaccine in college or before, or we don't know and can't find out which product they had?
Yeah, the work group did discuss that in depth. I think that is a major feasibility concern that we have. I think we really want to emphasize, the ACIP recommendation would be that to use the same product, that the doses are not interchangeable, or vaccine products are not interchangeable, just as it is for primary series vaccination. We recognize that that's a challenge during an outbreak. We've attempted to review with the work group potential guidance for our CDC's outbreak guidance document, understanding that we're not always going to get it right, but that we do feel that these students should be offered the chance to get a booster vaccination. And Rutgers presented, the New Jersey University presented to us about their experience, and it does sound like that was a challenge, but they overall felt that was something they could work with.
Dr. Hunter.
Yeah, just to respond to that, I'm looking at this, and correct me if I'm wrong, but that the booster recommendation gives more flexibility rather than limiting the direction of an outbreak response, so that at least if you find out later that you vaccinated somebody a second time, you didn't do something that was against a recommendation.
Dr. Freixo.
Sandra Freixo for American Medical Association. As a practicing physician, I've had difficulty figuring out which of the vaccines my patients have received. It's not indicated on our GRITS registry, and oftentimes I have to call the pharmacy or call the pediatrician, which can be quite cumbersome. So just a shout out to include the specifics on the registries and in notes.
Dr. Ewan.
Yeah, I was just going to add that I think with the general lack of a broad recommendation for all entering college students to get the meningitis B vaccine, having it be a clinical decision-making and the low uptake at this point of MenB, we would understand that we have some who have had previous doses, but I think we'd be looking at it more like this is the initial outbreak dose, so that the booster might be the flexibility for those who had already had some at some point in the past. But I think we'd be thinking more like this is the outbreak dose that we're under recommendation to give.
Any other comments, questions? Okay, since we're going to have to vote on this in the afternoon, could I have the wording proposed for the vote on the screen?
Yes, that's slide 53.
Okay. So do members feel comfortable making a motion at this time? And if so, then can I have somebody make the motion?
So
Dr. Stevens.
I'm moving that ACIP recommends MenB booster vaccinations in persons age greater than or equal to 10 years at increased risk for serogroup B meningococcal disease who previously completed a MenB primary series.
Motion second. Do you have any comment? He's already motioned, so you have a counter motion? Then we'll hear your counter motion.
Just listening to the conversation, I'm struggling with the fact that we have a great deal of uncertainty and acknowledge that we still have to make a decision in the face of that uncertainty. So I'm comfortable with that component of it. I strongly do feel that there should be, I don't know what the equivalent is of like a post-marketing commitment or requirement specific to this area, but something like that in this area, because I do feel like additional effectiveness and safety data are needed, including with the interchange of the different products if that happens in an outbreak setting. But the counter motion I wanted to put on the table was to consider shared clinical decision-making, which I know is not going to be a favorite in this room. But the reason I say that is partly because of Dr. Quach's comments about are we making a blanket recommendation in the face of uncertainty versus a recommendation that allows people to use their judgment. There are some populations for which I feel more strongly about it, and others where I feel like it's less clear to me what the right answer is, and we're mixing them all together, so I'm struggling with it. So that was a very long motion, and I apologize. But the motion is whether to consider shared clinical decision-making for populations who remain at increased risk, of which I think they are a heterogeneous population.
Do you have another motion?
No, I didn't have a motion. I wanted to support it, but I wanted to ask if there was can you make or can you support a motion with a condition?
Yeah, an amendment.
So with an amendment. So what I was considering is that I agree that we don't have all the data that we need, but I think we have enough data to make recommendation if we are also commit to collecting the data. So I was thinking to support the proposal, but in a recommendation, but attached to it that if we have enough people, we have 100,000 people with sickle cell, for example, that we actually collect this data in a way that is not left hanging. So I don't know if when you support, you can make that amendment.
So your amendment to the motion is to Dr. Stevens' motion,
yes.
Is that correct?
To say I support that with this amendment condition. I don't know if that's possible.
Okay, so we have two motions on the table. At this time, then, I think we should go with Dr. Stevens' motion as chair of the work group for seconding, right? We have to.
Just confused about. I mean, usually recommendations don't have the language that Dr. Eche included. That's sort of part of the paragraph, right? So that could be included regardless of the recommendation language. I was just trying to reply for that before you.
That's good. Very good. So we'll have a second. If the motion is seconded, then it will be carried forward to a vote. If it is not seconded, then we would move to Dr. Lee's motion for seconding and then carry forward to a vote. Eche, do you have another question?
No, so I will second it, if it allowed. I'm just saying that I was just asking what I want to be able to do is to say that secondly to move forward, but that we include, I really do think we should include that data collection.
Now comments. So Dr. Atmar.
So can I request that over the lunch, less than an hour now, that a counter proposal reflecting Dr. Lee's recommendation be drawn up so that in the event that this is voted down, we can look at the counter. Maybe we can even look at it before we vote to help us guide our decision on the first vote.
I think, yes, that would have been something I would have suggested, but I think we can do that. Dr. Talbot.
I feel like I've missed something really big, but this recommendation doesn't say when to do this. Or how often. So is it a year after they finish their primary series? Is it 2 years? Is it as soon as they finish their primary series?
That was on the table on the prior slide. Do you want to pull that up?
Yeah, that's better. Okay, thank you.
So I just want to clarify from a procedural perspective that, so ECHE has put an amendment on the table. Technically, if that amendment is seconded, then we would need to vote on the amendment and then vote after the public comment on the proposed amendment. I think Dr. Messinger's comment that we can incorporate that language and not include it in the policy is also an option, but I just wanted to make sure that there was nobody who wanted to second that amendment.
So I need clarification of that, because I thought that by your statement, you were saying to include it in the statement.
No, I'm sorry. I guess what I'm saying is, we have really worked over the past, especially the past 5 years, to make the recommendations very clearly a recommendation around vaccination and not to have other language, because I think, many years ago, the recommendation language was so complicated that folks really felt like it was difficult to understand. And so we've really tried to get to a place where your recommendations are clearly ACIP recommends, give a vaccine, you don't give the vaccine, clinical guidance, but that the language that Dr. Etche said could be part of that whole paragraph where we lead up to the actual recommendation. And, eventually you guys will see a statement and it can be in there regardless, therefore, of actually including it in the thing that you vote on. If that makes sense.
Great, thank you very much. So are there any other comments from?
Yeah, we're just a little confused back here. The shared decision-making potential amendment, is this just for persons at increased risk for meningitis, or is this across the, because we do have some concerns about shared decision-making in an outbreak. I mean, that's going to be challenging for those of us who deal with outbreaks. It's different than an individual, but maybe we're misunderstanding back here.
Yes, it is shared, and we'll come back with that after lunch.
Not yet.
Okay, so more comments?
I just want to comment in support of the original recommendation, in that the reason that a routine recommendation is important for boosters for these individuals at increased risk is that there's no question that they need boosting in order to be protected against hepatitis, wrong work group, meningococcal B disease, whatever the disease is du jour. And so there's really no question that they do, if they wish to be protected, then, and they are at increased risk, they need to be boosted, and the best evidence that we have is 2 to 3 years later. I think ongoing information is important to collect to understand if, that is forever, if we're able to stretch that out as more data become available. But I think that that's the reason that it needs to be a clear guidance that if you're in one of these increased risk categories, it's a recommendation, it's not a requirement. People choose all the time not to get vaccines that are recommended for them, and they can certainly do that. Yeah. But for protection, they need to be they need to booster.
Can I just clarify? I just wanted to respond. Is that okay? My response was, I was not talking about outbreaks. I was talking about the first population. Thank you.
Dr. Stevens.
So I was going to make the same comment that I think shared decision-making is very difficult in this setting where you have obvious risk. Interpretation would potentially be different. I mean, these are individuals with ongoing risk that is not going to necessarily change, and to be soft, if you will, in terms of the recommendation, I think is a mistake. So that's.
Edge had a comment, and then.
Well, I actually just wanted to put on record that I do think that this is not one of those that where shared decision is going to really help guide what we do. That that if we are going to make this recommendation based on the data we have, recognizing even the limitation of the data, that we should make that recommendation and be able to get the data that will guide us when we review.
Dr. Freixo.
Sandra Freixo for American Medical Association. I'm speaking as a practicing physician. You have to think about who's giving these vaccines. I mean, it's people in, private offices. They're, public health people. They don't have the expertise that you do around that table. And believe it or not, when ACIP makes a recommendation, it's not a law. There is shared decision-making that goes on with that patient and the person providing the immunization and offering it. And we need specific guidance. I mean, I think the shared decision-making is a little bit of a cop-out.
Dr. Hunter.
I'm not against the shared decision-making possibility for the high-risk groups, but I'm just wondering if I understand it correctly that the initial recommendation for vaccinating these high-risk groups is a routine recommendation, and it's not individual decision. Okay, so if we went with a shared decision-making for the booster, then that would be routine for the initial and shared decision for, okay. Just want to make sure I understood it correctly.
Yeah. Yes, I was going to say you're next.
Withdraw my proposal but I will say this but I want clarification on two things.
Your proposal or your motion?
My motion, sorry. But I'm hoping for clarification on two things. So number one, in terms of microbiologists, and the reason I'm thinking about this is partly because if this becomes a recommendation, then I think that might become a requirement for healthcare workers in that setting to receive that vaccine. And if they opt out, there might be a potential consequence. So just thinking about that, what Dr. Quach said, is she still here? Oh, okay. Well, what she had said about, have we really changed the way we practice, and has the risk changed at all? In thinking about that, I'm realizing that we don't often know what an isolate is when it comes in the door. So it's like, I think that enhanced protection actually still makes sense, because in the known setting, it's a different thing, but in the unknown where you're working up an isolate, I think that's different. So that takes care of that question. And then the other is specific to the asplenia population, and then the balance of prophylaxis and vaccination, and we would not stop prophylaxis, in those patients who have ongoing asplenia for multiple reasons, some of which could be sickle cell, but it could be due to a variety of reasons. So I just want to make sure that, again, we think about the ongoing safety of that and the benefit-risk balance for that population. No challenges at all with people who are on eculizumab, who are at extremely high risk for MenB or meningococcal disease in general, as well as the other chronic complement deficiencies or chronic disease issues.
So, personal note, just anecdotally, that scenario that you pointed out clearly happened at our hospital very, very recently, where the isolate, you don't know that you're working up, you have no idea that that's going to be the case, and it turns out to be a major exposure. Dr. Stevens and then Dr. Maldonado.
Yeah, I do think the Save Our study that was done in 2005 probably needs to be updated. I think the point that we are now looking at safety issues more effectively, maybe in clinical microbiology laboratories for meninge, but the point is you don't know sometimes, and some of those cultures are still done without the kind of protection that you would need. And so it's the unknowns that I think are the big concern. But I do think, to all of our points, that more data is probably indicated to look at risk.
Right. I mean, David's looking at me because that Save Our study was mine. So, right. But I also think that the relevant thing here is that the Save Our study was done at the time, if you look back at the epi curve that Sarah showed, when meninge rates were higher. And so we were able to demonstrate an increased risk. The absolute risk now is so much lower that it's going to be much more difficult to actually identify whether or not there's still a substantive risk associated with laboratory exposures. But the problem is, of course, it's an occupational health hazard. And I think that it would be difficult, unless there's concrete data saying that they're not at risk, to take it away because of exactly these kind of incidents, which, I mean, this partly started when there was an incident at Emory University that, was tragic and, preventable because there was a vaccine.
Dr. Maldonado.
I have a question. I guess I'm a little confused now. So I think when Dr. Hunter mentioned that this is it's a routine recommendation. Oh, it is on. Sorry, it is a routine recommendation. Are you talking about, anyway, my understanding is that the meningococcal B vaccine is a shared decision-making vaccine, not a routine vaccine.
This is,
right?
so you are correct on it. This is for the high-risk people.
Right.
So we have a routine recommendation for persons who are at increased risk, these groups that Dr. Mbaye has been talking about, and that is the only group which we're considering for.
I just want to clarify this because I've gotten lots of emails from our members from the Academy, and they're concerned because they said, does this mean we have to start vaccinating everybody because we're afraid they might be enough? So I'm just, we've talked about this, so I think we just need to make it really clear. The vaccine itself is not routinely recommended. The booster is recommended, is going to be, or you're going to vote on whether it's routinely recommended for people who've already been vaccinated. But they're starting to ask, does this mean we're now going to have to do the primary series too, where that's a shared decision-making responsibility?
Dr. Kimberlin.
Okay, now I'm confused, and I'm with her. Put it to the next slide, please. The vote number 1 slide. Okay, does that include college students? Okay, thank you.
So just to clarify, this is only for people who are identified at being at increased risk for meningococcal disease. We did include some language which we would put in our information,
But your table, I'm sorry to interrupt, but your table does talk about outbreak, which is college students, and that's why.
Can we update the recommendation language over lunch? How about if I think the problem is that your language that you put up for a vote proposal is probably, you simplified it too much, and so how about over lunch?
Separating
we fix it and then come back after lunch.
That'd be great, and I assume since it says vote number 1, that means there's a vote number 2?
There's another vote.
Do we want to see that language before lunch?
Yeah. So if we're going to, so we may need to have remotions done because you're going to wordsmith that motion at this time. So I would propose, if that's okay with you, Amanda, and with Dr. Messonnier, that we work on the wording of this, we come back again, and then make a motion. If Ece wants to add his amendment, we add the amendment, motion, then have a second on that, and we'll move forward.
Will you ask Dr. Stevens to withdraw his motion at the time?
Yeah.
Can I ask the CDC leads go back and write language that includes as background what Dr. Ece asked, which would clearly be part of what we would be saying, and show us that as well as the actual recommendation language?
So I'm going to ask Dr. Stevens first, and then Ece to withdraw, if you're willing to withdraw your motion, and then have it reconsidered after lunch. Will you reconsider that, Dr. Stevens? Dr. Ece?
Yes.
Okay, both motions have been withdrawn. We're now going to take a 45-minute break, right? And be back here at...
So just to clarify for everybody, we're going to take a 45-minute break. We're going to be back here at 1:30. We were supposed to have the public comment period at 1:30, but the public comment period will happen after this session is complete.
Okay, so we'll begin the afternoon session. I'm going to ask Sarah to go back up, Dr. Mbaye to go back up, and we're going to have a motion on the language for the votes for the meningococcal vaccines. So right now there are 2 motions, right? Well,
we withdrew all motions.
Right, no, but there are going to be 2 votes on this. Okay, so why don't we have the first?
Let's have Sarah just.
Sarah, go ahead.
Thank you. So just before we start with the motions, I just wanted to quickly remind everyone what the current recommendations are. for MenB vaccines. So ACIP recommends that persons aged at least 10 years who are at increased risk for serogroup B disease receive a MenB primary series. That's a routine recommendation for everybody in this group at increased risk, which is listed below. In June 2015, ACIP recommended that adolescents aged 16 to 23 years may be vaccinated with a MenB primary series based on individual clinical decision-making. So for these groups of adolescents who are not at increased risk, this is a clinical decision-making recommendation. So now I'm going to go through the revised language for a vote. For persons aged at least 10 years with complement deficiency, complement inhibitor use, asplenia, or microbiologists, ACIP recommends a MenB booster dose 1 year following completion of a MenB primary series, followed by MenB booster doses every 2 to 3 years thereafter for as long as increased risk remains. For persons aged at least 10 years determined by public health officials to be at increased risk during an outbreak, ACIP recommends a one-time booster dose if it has been at least 1 year since completion of a MenB primary series. A booster dose interval of at least 6 months may be considered by public health officials depending on the specific outbreak, vaccination strategy, and projected duration of elevated risk. And then we've included some additional guidance based on the feedback received. These recommendations do not apply to persons who previously completed a MenB primary series as an adolescent based on individual clinical decision-making and who are not at increased risk for serogroup B meningococcal disease. MenB vaccines are not interchangeable. The same product must be used for all doses. And collection of safety and effectiveness data for repeated booster doses of MenB vaccine in persons at increased risk for serogroup B meningococcal disease is needed for the ongoing evaluation of these recommendations by the ACIP meningococcal vaccines work group.
I'm sorry to interrupt, but will you just take out work group because it's by ACIP, not
Okay.
work group?
Sure.
All right. Are there any questions, comments from the voting members? Dr. Szilagyi.
Yeah, this is very clear now to me, much better.
Okay. From the liaison members, do they have any comments? Okay. None being, I just want to make sure I'm going around. I can't see everybody, so I want to make sure I'm not missing. Yes. Oh, there's a thumbs up.
We think that's much clearer.
Fine. Thank you very much. Again, like I said, I can't see everybody, so I'm just sort of bobbing and weaving here. Okay. So I will need a motion for this proposed vote. Dr. Stevens.
I make such a motion based on the language outlined on this slide.
May I have a second to this?
I will second Dr. Stevens' motion.
Thank you, Dr. Lee. Okay, so rather than, are there any other comments or questions? All right, rather than read the whole thing all over again, you have it in front of you.
We're not voting right now.
But we're going to move it to the vote, right? So it's carried. We're going to move it forward for vote. Right. Okay.
Sarah has one more presentation.
We have. No.
Just to clarify, there's one brief additional presentation on the statement before we move to public comment.
Right.
Yeah.
Sarah.
Okay, so now I'll review the updated ACIP statement for meningococcal vaccination in the United States. The last statement was published in 2013 and included ACIP recommendations for quadrivalent meningococcal conjugate or MenACWY vaccination. Since this time, 5 policy notes related to MenACWY and recently licensed MenB vaccines have been published. In 2019, an updated statement was developed to consolidate all existing ACIP recommendations for MenACWY and MenB vaccines in a single document. In addition, if ACIP votes today to recommend MenB booster doses in persons at increased risk, these recommendations will be included in the document. The objectives of the updated statement are to describe the background on meningococcal disease, epidemiology, and risk groups, provide updated information on currently licensed and available vaccines, describe the process undertaken and rationale used in support of ACIP recommendations, and provide ACIP recommendations and guidance for use of meningococcal vaccines. We conducted a systematic review of the literature related to safety, immunogenicity, and effectiveness of MenACWI and MenB vaccines in the age groups in whom the vaccines are licensed. We consolidated and clarified existing MenACWI and MenB recommendations and drafted preliminary MenB booster recommendations. The draft statement was shared with workgroup members and ACIP voting members to provide an opportunity for feedback prior to today's meeting. We included information on the 4 vaccines that are currently licensed and available in the United States, 2 MenACWI and 2 MenB vaccines. Additionally, 2 vaccine products included in the previous ACIP statement are no longer available in the United States: polysaccharide meningococcal vaccine and a combined Hib and meningococcal serogroup C and Y vaccine. Thus, detailed information and recommendations related to these 2 vaccines are not included in the updated statement. We included all recommendations for the currently licensed MenACWI and MenB vaccines, starting from MenACWI introduction in 2005 through preliminary MenB booster dose recommendations in 2019. Key changes in the updated statement include a compilation of all existing MenACWI and MenB recommendations, as well as the proposed new recommendation for MenB booster doses in a single document. The previous Category B language for MenB primary vaccination in adolescents will be updated to ACIP recommends a MenB primary series for individuals aged 16 to 23 years based on shared clinical decision-making. In addition, the appendices with guidance for chemoprophylaxis of close contacts and management of outbreaks are no longer part of the ACIP statement. Guidance for these aspects of public health management are included in CDC guidance documents. Thus, today's vote consists of affirming the updated statement related to meningococcal vaccination in the United States.
Are there any comments, questions from the voting members? From the liaisons? All right. May I have a motion for this vote? Dr. Stevens?
So I move that ACIP affirms the updated statement of meningococcal vaccination recommendations of the Advisory Committee on Immunization Practices.
May I have a second, Dr. Frey?
I second Dr. Stevens' motion.
Any discussion or questions? Okay, this will be voted upon this afternoon.